So now I invite Sujeet Ranjan, and we have Sujeet Ranjan's deck. So Sujeet Ranjan was referred to me by my research student who still works at Tata Trusts on livelihoods. And I'm thankful to Sharda Gautam for introducing me to Sujeet. I didn't know him until about 2 to 3 weeks ago, and we have been only speaking on phone. Sujeet Ranjan has been associated with the public health sector for more than 2 decades. His experience includes large-scale program management, policy advocacy, and partnership management. He is associated with United Way of Delhi, India, as Chief Executive Officer. Prior to this, he was leading large public health nutrition initiative of Tata Trusts, the Coalition for Food and Nutrition Security (CFNS), and with CARE International to raise awareness, foster collaboration, and advocate for improved programs to achieve sustainable food and nutrition security in India. Sujeet has also undergone the International Fellowship Program on Visionary Leadership and undertaken a fellowship on leadership at the Center for African Family Studies, Nairobi, Kenya, and with the NFPCB, Government of Indonesia, Jakarta. Warm welcome, Sujeet.
Thank you very much.
Very wonderful that you could spend so much time yesterday also in getting the diverse perspectives that are being discussed here. Welcome.
Thank you. Good afternoon, everyone. And it gives me an immense pleasure to be here, and I'm really thankful to Professor Vijay Raghavan for giving me this opportunity to be here. And since yesterday, I'm listening and learning lots of new things. To be very frank, I was not part of all kinds of like Ayurvedic medicine, the theory, how they are taking care of critical cases, as well as homeopathy. Because I am from the program management background, health management background, and I got an opportunity to lead large scale health program, mostly the public health nutrition, India as well as in African countries. So my presentation is also very much related to public health nutrition. It has two parts. Again, this presentation is different from I'm listening from since all of you from since yesterday. So this presentation has two parts. One is the issues, the challenges, as well as the possible solutions, suggestions, ideas, and how that is working well. So this presentation is public health nutrition, and nutrition, we know that it's very important for each one of us, but so far as the priority of nutrition is concerned, again that is a questionable things. People are having different meaning for nutrition, different understanding for nutrition, but nutrition, we know that how that good nutrition has power to transform not only the present as well as the future generation. And it is very much important for the especially the children, the mothers, and also like how the foundation of a child can be totally based on the nutrition. And since I'm a student of development studies, I have learned from Professor Sumakar how small is beautiful, and how the small initiative can lead to a large impact. And that's why, like for more than 20-25 years, I'm in this field of nutrition. The problem in our country, as we know, that almost half of our children are suffering with different kinds of nutrition. More than 57% mothers are also suffering with anemia. That's the huge issue. But at the same time, we understand that our sustainable development goal, all 17 indicators of sustainable development goal are basically dependent upon the nutrition. If the nutrition is improving, all the indicators will also improve. So that's the importance of nutrition. So far as our country is concerned, we know this fact that our we are having the largest population most in the world. So the greatest treasure of our country is the human being. How we can take care of their well-being, nutrition, and well-being. But at the same time, the recent data has given a kind of some kind of satisfaction, but at the same time a big jolt about the severe acute malnutrition. Though there is a success, I can say, or there is a downfall in different kinds of malnutrition, but severe acute malnutrition that has increased by 0.2%. And the most alarming is the 67% children are suffering with anemia, and 57% mothers are suffering with anemia. And children, we know this fact very well, cannot wait, because every day is very crucial, every day is important. Like again, this is based on my learning, my assessment. That's why I said that the issues problem. Like what are the issues I have identified? Like maybe some of the learnings which I am having since yesterday will be very useful to take this challenges into a kind of possible solution. But we are having a very vast, India is having a good network of nutrition initiative, the institutions, almost 138,000 Anganwadi centers, that the nutrition center in our country. So every pockets, every village, every like Anganwadi center is catering the population of the mother and child. But in spite of that, the implementation failure is the big problem. The poor utilization, demand, because I mentioned about the priority, nutrition is not the priority. So the priority, then the demand is also not there. If the demand is not there, we are not in a position to hold the people accountable or responsible, those who are responsible to provide the services. The capacity is a big issue. Understanding, because most of the things are in a delivery mode, most of the things are not in a kind of problem solving, rather the delivery mode. We are providing the food commodities, but how the food is going to be utilized, how the food will be going to be age appropriate food can be provided. So there is a big issue. And the behavior change, how the behavior related with the hygiene, behavior with the water, behavior with the open defecation things in our country, sanitation. So that's the big issue here in our country. Now, this is again our understanding, because our understanding is mostly related with the intermediate cause. That's the intermediate cause. Mostly we think nutrition means food. If there is something related with food, that means that is causing malnutrition, that is leading to a poor health. But we understand the underlying causes, hardly we understand the basic causes of malnutrition. And this is very important, that it's not only just food, inadequate access to food, access is the important thing, then also the inadequate care and the insufficient health services which is meant for them. And now since yesterday what we are listening from Ayurveda and homeopathy, Unani, I think that kind of services are not available there to take care of the poor children and the mothers. Then the basic cause is very important, like the status of women, how the status, if I am saying the status, because they are the gatekeepers, they are providing the proper care to the children. So that is the missing link, the political will, then the economic structure. So the basic and underlying causes hardly we understand whenever we talk about the nutrition. We also, this is again my learning, that low birth weight baby is the major cause for the malnutrition. That's almost 20% cause. Then the illness, we just heard that danger sign, how we can understand the danger sign. If the illness is there, how can reach out to the service providers or the health functionaries, locally health functionaries. That is not there. So that's why the 25% illness is the cause of infant mortality. Then the major cause is the malnutrition, that is 55% children are suffering with malnutrition. And that is the like since independence we are having all kinds of program, but somehow in this program Ayurvedic and the homeopathy Unani are not properly linked, properly aligned. We know that this fact, based on again based on the last slide, the early identification is very important. How we can identify the danger sign if the child is suffering with malnutrition, what kind of danger signs are there and how that can be identified, how the prevention to be at kind of should be the first model rather the curative. The preventive health is the most important thing here, and the shifting focus to the younger, the first 6 months is the most crucial, and the first day, first hour, first day, first month, first year, and the 2 years, the 1,000 days. So that's the most important. And how we can give the prime focus to the severe acute malnourished children, because that has the number is very high, and in comparison to the other parts of the world. Then community based management, how the community can ensure the community based treatment, community based preventive measures can be taken care of, and the strategy for manage the acute malnutrition in the seasonal peaks. Seasonality is very important. I have written a book on the seasonality on the malnutrition. So this is also very important, how the seasonality is creating a kind of issues related with the malnutrition, and hardly we understand, and that's why we are not preparing ourselves, the mothers and the family and the community. The first 1,000 days, this is we thought like though that is the agenda of the policy makers also, but at ground level, at community level, we thought that this is the best way how we can take care of our children and the mothers first 1,000 days. And that is the from the very beginning, like how the first during the pregnancy, how the we can take care of the mothers very well, so that the early registration, the vaccination to the mothers, the proper nutrition to the mothers, then the birth preparedness as well as the birth delivery, and the early initiation, the exclusive breastfeeding, then the complementary feeding, and then finally the immunization and the first 2 year proper care. So this model was already there, but how we develop this model, which can easily understand by the community and understand by the common people. So that we have developed, and I'm just sharing one example. That is the initiative which was started by us. That's the Gram Varta. Gram Varta means it's the collective of action, and Gram Varta means village dialogue. It's a village dialogue, and this model was developed by an organization called Ekjut. Started with Ekjut in Jharkhand. There is a place called Chakradharpur. They are Dr. Prashant Tripathi. So we collaborated with Ekjut and developed this model like Gram Varta. How we can ensure that all the mothers, all the male members, because male members were not part of this program, how we can engage them in a meaningful manner, and how they can understand the importance of nutrition and how they can take care of these things. So Gram Varta was a focused communication at village level, and like twice in a month they were having session at community level. Half an hour session was basically on the issues, and the rest was the discussion. And discussion means we again the theory of Robert Chamber, because I'm also a student of Professor Robert Chamber, who says that usually our understanding is we know, they do not know. We are the problem, they are the solution. But how we can change? They are the solution. We are basically we are the problem. We are bringing our own thoughts. So how to learn from them? How we can increase that how we can provide a platform where people can come forward and talk about the issues related with their health, the accessibility, the availability, the utilization of the services, and So Gram Varta was basically for that, and Gram Varta was having not only just nutrition food, it was related with the nutrition garden, how the nutrition garden can play an important role. Later on, government India also decided to Poshan Vatika, but it was started by the nutrition garden. It's not the kitchen garden, it's the nutrition garden. How the difference between these two, how we can understand the importance of nutrition. Then nutrition, not in isolation the food, rather the water, proper water, the sanitation. Then the early marriage, how the early marriage was also an issue, how that can be taken care of. Then some kind of economic involvement of the mothers, so that they can also generate the resources, and how they can utilize the resources for the children. Hygiene was the important factor, and we created nutrition champions through the Gram Varta. So small modules, they are not a big. So every village we are having almost the engagement. It's not a kind of very small and short term engagement. Rather, we decided to be there at least 6 months in every village. So 6 month, that means every month 2 sessions. So that means 12 sessions in every village, and then finally and handed over to the local self-help group. Like in Bihar, this was a very successful with Jivika self-help groups. Then the Women Development Corporation. Similarly, in Jharkhand, Ajivika was there, and the other places also. And this was the entire Gram Varta was based on the participatory learning and action PLA module, and the issues gradually, like every, though this was the key issues which I mentioned, but we are taking the issues, the local issues, how they can, and the solution also. And by this way, we are also involving the local service providers. They should not be any kind of threat that somebody is coming to somebody has come to fault finding that the Anganwadi workers are not working, or the Asha is not working, or ANM is not working, or the Gram Sabha or Gram Panchayat is not working. So how we can engage them in a meaningful manner? It's not a kind of threat, rather helping to all of them, so that the services can reach out to the community in a desired manner. And this increased awareness. The Gram Varta also increased negotiation skills, then the accountability among the service providers, awareness, and the PRI involvement. PRI involvement was not at all PRI involvement we found in the nutrition program. So accessibility and adaptability. So this is, by this way, we initiated from Jharkhand to Bihar, then the Rajasthan, Odisha, Chhattisgarh. So there are, so state by state we are moving towards that. And this also challenged lots of traditional social norms, because there was norms not for the early initiation. Early initiation will not take place in first 7 days, or even the complementary feeding. There was some traditional norms how that can be taken care of. And complementary feeding, it's not just kind of one biscuit, it's a kind of complete package, how the quantity, quality, age appropriate. So that was part of that, and encourage women to take the lead in the entire things. So this was the and based on this success of this Gram Varta, we started the women-led sustainable people movement, and this was the home visit, the prioritized home visit, how they can visit to the children, those who are 6 months old or 1 year old. So prioritize the social campaign on the community care. Again, the women farmer-led campaign was also there, part of that. Then the visit to the Anganwadi center, so the nutrition center, how they can go, get the services, how the quality services can be delivered from there, how the safe food campaign, and also the delay in marriage, the male engagement. The big problem, I tell you, like since throughout my life I have worked mostly on grassroots level. So I have seen like who is reaching to the mother. So there is only one functionary, that's the Anganwadi worker, is reaching out to the mother. Who is the next? ASHA worker. Since 2005, when the National Health Mission was launched, ASHA came into the existence. Then the ASHA worker. There is no male. There is no male engagement. That's why I started in the discussion that the status of women, who is taking the decision? Who is the responsible to take the decision? So it's important to male engagement. So this was the entire focus, and I'm very happy to share that we are getting the result, good result. Good result means you have seen like how the stunting has in the last 2021 the National Family Health Survey has also given a very clear picture. Stunting has come down, our underweight has come down. So this is the positive result, but we are still lots of the journey will it's a long way to reach out to the community and the entire pockets. And I'm also happy to share that in last family health survey, these data were also collected. So data means how the percentage of currently married women usually participate in household decisions, how they are having the 12 months the paid in cash, how they are having the mobile using the mobile phone, how they are having the bank account, whether they are having or not, whether they are having the owning the house or the protecting during the menstrual period, whether they are having that thing. So these are the data was very helpful for us, that yes, how the things are moving, where we have to put more efforts so far as the status of women and the nutrition is concerned. So this is the entire journey, and our Gram Varta is already on. It's going on very effectively. Lots of pockets are still left out, but we are very much hopeful that things will come in a better way. And the prevalence of anemia, which is very high, and now the Gujarat, Maharashtra, the richest state, are also facing this big problem of the malnutrition. Especially the anemia is the we are not expecting that the rich state like Maharashtra and Gujarat will have a large number of women suffering with anemia, and that was a research subject for us. So we spent a good number of days with the community, with the people, and try understand some of the behavior issues. And now the Gram Varta has developed a model to engage the local our health functionaries, local, now based on the learning we are having yesterday, and Dr. Girja also shared lots of things to me yesterday. I am planning to engage that model into our program. So this is the small presentation and the learning and the success of Gram Varta, and I'm very much hopeful that collectively together we can make a change, we can make a difference, and we can not only just make them aware, rather we can build the capacity already they are having, but giving the platform to the women so that they can take the lead role and they will be a real gatekeeper to address the malnutrition. Thank you very much.